Okay, so today what we're going to talk about is the integumentary system with quick recorded lecture for this chapter. So make sure you're watching this video. I posted it also in the links as well as some skeletal videos from Ninja Nerd. This is a quick one that goes over the layers of the skin and all the structures. So important to watch. I'm not going to watch it here. So we're going to talk about the different layers of the skin. The skin's made up of epithelial cells. It's also made up of connective tissue, and we have reticular or irregular connective tissue, and then we have loose areolar connective tissue, and that's providing the adhering properties of your skin and the elastic properties of your skin. Uh, and then we have the epidermis, which is made up of these 4 to 5 layers, depending on what skin we're talking about. So we have 2 types of skin. We have thick skin, we have thin skin, and most of our skin is thin skin, and that contains 4 layers of the epidermis. Thick skin, which is like found on the soles of your feet, the palms of your hands, fingertips, or parts of your fingers, things like that. Those can have an extra layer. We call this the lucidum right here. So the main layers are stratum corneum, stratum lucidum in thick skin, stratum granulosum, stratum spinosum, and stratum basal. These 5 layers make up skin. And again, if we're talking about thin skin, we would get rid of the lucidum layer. Skin is, or the epidermis has 2 main cell types. We have melanocytes, which are specialized cells um, that exist in the stratum spinosum, and they produce melanin. And they're kind of these larger cells. And melanin is the pigmentation that gives your skin interacts with the photons and the UV light, and it provides stimulus to create this protein called melanin that it secretes. And melanin has both a protective function in the skin to protect it from UV radiation, as well as a pigment function. It gives skin that all the different pigments. So these cells can become cancerous. We've probably heard of melanomas, which is a very aggressive form of cancer. And one of the signs of melanoma is an absent pigmentation. So you can have an area of skin where it's like not becoming pigmented. That can be a sign of melanoma, or you can have a hyperpigmented area that is continually getting bigger. Those are some signs of melanoma. Um, the other type of cell is called a keratinocyte, and keratinocytes are um, the main cell that we're going to see in the epidermis. And so what they are these squamous cells that start their life in the stratum spinosum. And I think spinosum is kind of like where they're spinning up. And in the spinosum, they are immature keratinocytes. And as they mature, their main purpose is to create this protein called keratin. And uh, as they're maturing and producing this keratin, they eventually will die. And when they run through their life cycle and become fully matured, they've produced a lot of this protein called keratin, which they leave behind, like a little keratin skeleton. And we call that keratinized. So it's composed of what's called keratinized stratified squamous epithelium. Um, it is what I would call avascular, right? So like all other epithelial tissues, they need to get their blood supply from surrounding tissues. The basal and the spinosum, kind of this basement membrane, and they interact with one another. So the basal is part of the epidermis, but it interacts with the dermis, which is this layer down here. This is where, again, the melanocytes and are like existing within the basal and within the spinosum. There are specialized macrophages within this part of the epidermis, and they're called dendritic cells. And these dendritic cells are immune cells that can help pathogens that may make it into your skin. So if you get a laceration in your epidermis or an abrasion, you wonder, man, why don't I get an infection every time that happens? Because there's a very unique layer on our skin on the surface of bacteria. It's part of our normal flora of bacteria. And this layer that covers our skin is made up of predominantly a bacteria called Staphylococcus epidermis. And it likes to form kind of a barrier sheet. And it helps actually with our protective nature of our skin. It protects us from fungal infections and other types of bacterial infections. But it's not meant to be in our tissues. It's meant to stay on the surface of our skin. So every time we poke somebody with an IV, or you get an abrasion, or do a procedure, or put a Foley catheter in somebody, or any of these things, you run the risk of introducing staph epidermis down into the layers, as well as other bacteria. And so when you get an abrasion, you get not only are you putting staph epidermis into your tissue, but you're also putting, whatever anaerobic bacteria that was, in the dirt, and, you know, Clostridium anaerobes like tetanus and other things that are present in those tissues. But why don't we get these infections? Why don't we get these horrible infections every time we get an abrasion? Well, some people do when they have weakened immune systems, but because we have these specialized immune cells, macrophages called dendritic cells, um, that help break down pathogens and prevent them from colonizing into our bloodstream and into our deeper tissues and creating infections. So we can talk more about those as we go on. But that's the basic layers of the skin and the structures. We talked a little bit about this. This is just histology of the layers. We have the basal, we have the spinosum, which is all of this, and then we have the granulosum, and then above that would be the corneum, or lucidum and corneum. And then these are finger-like projections are called, this is the first layer of the dermis, which are called the dermal papilla or papillary layer. And these are the little finger-like projections of areolar connective tissue that provide connection to the basal and the epidermis to these lower connective tissue layers, which I will talk about. As we move down in the dermis, we see different connective tissue. Now we have dense, irregular connective tissue. It's called the reticular layer, and this is where we have lots of elastin and collagen. And so when your skin is, nice and elastic as we're younger, we have lots of collagen, we have lots of elastin in this layer, and that creates we are continually replacing this. And as you age, a lot of the cells that produce collagen, these cells that produce these reticular fibers uh, break down, and we don't have as many of those cells. And so if you think about, like, as our aging population, when they lack this thicker, dense, irregular connective tissue, their skin loses a lot of not only its elastic uh, properties, but its strength becomes thinner, because now we just have this layer of epidermal cells and a little bit of areolar connective tissue. And so what happens is, when we don't have elastic skin, we don't have this strengthening reticular layer, the skin can tear very easily, right? And that skin can tear and break down, and it doesn't bounce back. And so, things like ripping tape off can just pull things of tissue, small abrasions can be pretty dramatic. And it can take a really long time to heal because we're lacking a lot of the cells required to heal rapidly. So it's important to think about this as we understand our aging population. And injuries that we might see. Particularly, we'll talk about some types of ulcers and things like that. Okay, so now if we move into the hypodermis, this is where we're going to see a lot of accessory structures um, and different types of connective tissue. And so we talked about the dermis, so we kind of have that papillary layer and reticular layer. And then as we move into the hypodermis, this is also called subcutaneous area because it's below the cutaneous membrane, which is made up of the dermis and epidermis. Now we're in the area where we're going to get more adipose tissue. And this adipose tissue, as well as connective tissue that surrounds it, this fibrous connective tissue, um, has several functions. One is it's an anchoring layer between the muscle fascia below our skin and the the dermal layer. It's also playing a role in insulation and protection. Again, as we age and we lose parts of this hypodermis, like this adipose tissue, we lose insulation, we lose impact protection that is sort of essential to this layer. Again, also we talk a little bit more about the vasculature. So the vasculature, the larger vessels of our skin are uh, in this hypodermal layer. Then we're going to, the arteries, the nerve bundles, the larger veins, lymphatic uh, vessels. So this is now getting into the deeper tissue layers before we get to the muscle. So if we get like a laceration down into the hypodermis, we can expect to see like heavier bleeding. Uh, we now have lost some of that immune barrier of the skin, some of that dendritic macrophages and things that provide immune protection. And so what we see is, higher risk of infection, things like that. Burns that extend into the hypodermis, we call these full thickness burns, right? They've extended the full thickness of the skin. And so um, it's an important structure in terms of, understanding the function of it, but also as we talk about other injuries and things like that. Okay, so when we talk about pigmentation of the skin, melanocytes are those cells that produce melanin. They excrete these little vacuoles. Remember, we call those kind of somes, that terminology for endosome, when we're bringing something into the cell. Well, melanosomes are something that are undergoing exocytosis from the cells themselves and are stimulated to produce those melanosomes by exposure to UV light. And so the more UV light exposure you have, the more melanin your melanocytes will produce because melanin has a protective effect to reduce the UV radiation damage to the skin. There's, like I said, these two main types of cells in our epidermis. We often think about like skin cancer as being a disease of sun exposure, right? People that get lots of exposure to the sun. And that type of skin cancer is what we call squamous cell carcinoma, or not carcinoma, or yeah, maybe it is carcinoma. I'm mistaken. But anyway, squamous cells, uh, malignancies are the ones that we see when people get exposed to sunlight too much and other types of, exposures to this to that might damage the skin. But most commonly, excessive exposure to UV radiation. And so these skin cancers tend to be like moles, growths, sunspots that become sort of invasive and can become malignant. And they're a little bit easier to catch because they tend to be in places that are exposed to the sun. Melanomas are much harder to detect because these cancers are actually not associated with UV exposure. Kind of what is a misconception about melanomas is that they can actually produce and be found in places like your toenails or, in under your pant line. And in your ear and in your under your armpits and different places where you wouldn't expect to see skin cancer, and that's because it's likely not as tied to UV exposure like people are thinking with when they think about like sunspots and other types of cancers. So melanocytes are generally a little bit harder to detect because you have to look in places that you wouldn't normally look, and you're looking for things like absent pigmentation or hyperpigmentation, like moles that have abnormal borders and are growing rapidly. Those can be signs of melanomas. And melanomas are very aggressive. They can infiltrate other tissues and spread, metastasize into all sorts of different organs and can have a pretty high mortality rate if they're not treated right away. All right. So accessory structures in the skin, these include things like hair follicles, glands, our nails, and our sensory structures. So we're going to talk about all of these. Okay. So here is a hair shaft and or what we call a hair follicle. It's made up of the shaft, the inner sheath or the root, which has some blood vessels. There's also usually associated uh, sensory structures, which are very close, which is why it hurts to pluck out a hair. Then we have a sebaceous gland, which is a alveolar type gland that we see made up of epithelial cells that produce an oily substance called sebum that excretes along the hair shaft out to the surface of our skin. These can also become infected, cause like sebaceous cysts, which are where we get a little bacteria and inflammation trapped in these sebaceous glands, and we get an infection that sometimes need to be treated. The erector pili muscle is a muscle that exists alongside each hair shaft. And if you ever heard you know, saying like when you get really scared, your hair stands up. Well, that's because these muscles are responding to epinephrine, and they have adrenergic receptors on them, which stimulate contraction of these muscles. And so the contraction of these alpha receptors that are on these erector pili muscles. So when you have a fight or flight response, contract the muscles and cause your hair to stand up. We also have uh, different structures, which we can see here called sweat glands. In sweat glands, we have apocrine sweat glands and eccrine sweat glands. And eccrine sweat glands are most common in our skin. If you've ever like gotten really sweaty doing a workout or something like that, that's mostly what we call eccrine sweat. And eccrine sweat glands produce what's called a hypotonic solution. So it's mostly water. And that it does contain some salts, so we do lose salt through that sweat, but it also has antimicrobial properties as well. And that antimicrobial properties can be protective from pathogens against from entering into our skin. Um, Apocrine sweat glands are found in places like the armpits and inguinal areas, and these apocrine glands undergo a little bit different type of um, secretion. So eccrine sweat glands, they're producing, through exocytosis, this sweaty, watery substance. We're losing water and salt. Apocrine glands, remember, they undergo what's called like merocrine secretion, where the tops of the cell basically ruptures off. And that is a hypertonic solution, so it's much thicker. It contains lipids. It's also very antimicrobial. Um, and it's also associated with our body odor because it is that thicker lipid. It contains bacterial substances. It is more oily, thicker. And so if you think about like, you know, sweaty armpit versus sweat on your skin, you can think like it's kind of like a thicker, grosser sweat, whatever, however you want to think about it. But there's two types of glands that we see. And then the sebaceous glands produce that oily substance that kind of provides some waterproofing and protection to our skin. All right, so we talked about here is a tubular gland, tubular acinar gland. These are glands that exist within our skin, uh, uh, or tubular alveolar gland. I think that's what's called. Sorry. This is against our hair shaft or hair follicles that are producing sebaceous fluid to secrete in the hair shaft. Okay, so we're going to talk a little bit about the sensory structures as we get into the next couple weeks. We're going to be talking about the nervous system, and so we're going to get more and more into the physiology of receptors uh, in terms of nervous sensory receptors. and we're going to be getting into the physiology of how the transduction of these signals occurs. So we're going to just sort of intro some of that because there are some specific sensory structures within the skin. And we have a couple. They fall within under the somatic nervous system, and they are following the sensory pathways. So they travel up the spinal columns, and we'll talk about what part of the spinal columns later. I don't want to over confuse you with that, but they travel up the spinal column towards the through the hypothalamus and into part of the midbrain where we have different nuclei or bundles of neurons that interpret sensory information and transmit that to different parts of the brain. And so what we have are things called the Meissner corpuscle, also called the tactical corpuscle. We have the Pacinian corpuscle, or lamellated corpuscle, which is another name, and then nociceptors, mechanoreceptors, and Merkel cells, or Merkel discs, sometimes they're called. So Meissner corpuscles and Pacinian corpuscles are going to be kind of our main uh, sensory sort of sensory cells in our fingertips and areas of our skin where we have light touch, vibration, things like that. So we're transmitting information about light touch, also temperature, up our spinal cord to our brain. There's a lot that goes into that, which we'll get into in the later chapters. And so these receptors uh, are their nerve. Or here, let me draw this out so you can see a little bit like so I'm not as rambly. So if I have a neuron, right, and at the end of this I have our nerve cell or axon, like we looked at that too in the slides. At the end of this, I have a Meissner corpuscle. So a specialized nervous system, nervous tissue cell, and it's part of an axon terminal. And so this is going to take in information from pressures put on the skin uh, about light touch. It's a very sensitive receptor. So we might see these in places where we have very sensitive skin. You can think about your fingertips are fairly sensitive, right? We can uh, feel things with at a very minute amount of pressure, right? If I'm just typing on a keyboard or moving a computer mouse around, those are all light touch. There's also Pacinian corpuscles, which are a little bit deeper into the nervous system, the sensory structure layers, and those are going to respond more to vibration. We also have temperature, so hot and cold. So a lot of different things go on when we are taking in information through our skin. We also have nociceptors, and nociceptors, these receptors are receptors that are all throughout our tissues. And nociceptors are pain receptors. They respond to pain signaling molecules. So if I have damage, right, something that's causing damage to the cell, I produce molecules or release pro-inflammatory molecules, right, or chemicals. And that can stimulate nociceptors to tell, hey, there is something going on to these cells. And this happens so rapidly, right? We can think about how quickly we can feel pain. So when we get stimulation of nociceptors, that can create a pain signal. And then mechanoreceptors are receptors that respond to direct mechanical uh, pressure. And so these are opening their sodium channels as we're applying pressure to those mechanoreceptors. They and then Merkel cells, we'll talk about a little bit more, but Merkel cells are another accessory sensory structure within the skin. Okay, so what we're going to talk about is the thermal regulation within the skin. So thermal regulation is one of the feedback loops that our skin plays an important role in. And it's also an important assessment tool, right? We're probably taught look for pale, cool skin and in our sick patients, right? Well, there's more to that discussion. And now, as you're becoming paramedics, it's important to really know the nuance in skin assessment for your patients and skin temperature and skin color and things like that. So let's just talk about the basic concept here is that our skin is our thermal barrier. It prevents heat loss, and it does that by interacting with our blood are the subepidermal blood vessels. And so we can, the little capillaries that project through the dermis that get close to the epidermis um, allow for a lot of heat transduction to this through the epidermal layers, and we get what's called evaporative heat loss because we have some moisture on our skin that causes evaporation, and we lose that heat is readily lost through the epidermis. So our core temperature can go down. And so let's say if I'm out for a run, my core temperature is going up because my metabolic rate is higher. And so what I'm going to do is prevent the vasoconstriction, I'm going to send a signal to my an inhibitory signal to allow for vasodilation of this precapillary sphincter. And so this precapillary sphincter is going to um, allow blood to move from the vasculature into these surface capillaries. And that surface capillary is going to allow for some heat loss, evaporative heat loss through the skin. And you're going to expect to see somebody who's very flushed, right? When they get hot, somebody gets flushed. You can think about that because that blood is closer to the skin. Then in the opposite direction, if someone is hypothermic and we need to protect the core temperature from going down, what we need to do is shunt blood away from the skin. And so we close the precapillary sphincter. Blood now is bypassed away from the epidermis, and so skin gets a little cooler, skin feels pale, or skin looks pale, and we can think about uh, now we're protecting that core temperature, so we're not losing that heat to the surface of the skin. And so this is regulated by the hypothalamus, which is sort of the overseer of all of our autonomic functions and where a lot of sensory information is input from our spinal columns. And a lot of signals then are bypassed down the spinal column and cranial nerves to change in effect. Um, Things can change this process by kind of adjusting the thermostat within the hypothalamus. So like our inflammatory mediators and our interleukins, like interleukin 6, for example, which can be released during bacterial infections and things like that, can turn the thermostat up, which would create a higher metabolic demand in order to raise our core temperature. But naturally, our core temp is somewhere in that, 98.6 or 37 degrees Celsius, right? And so certain things can change that. Like I talked about, certain bacterial infections, other types of infections or inflammation can say, hey, we want a core temp of 101. So what can happen is now we have to um, shunt blood away from the skin. We have to do things to get that core temperature up. We have to increase metabolic demand or metabolic rate, and we get a higher temperature. Okay, so if let's see, if let's say was having you do an assessment of a patient, and in EMT class, a really easy assessment tool what we might teach is say, look for a patient that's pale, cool, and diaphoretic, right? Well, what is happening in a pale and cool patient? Well, this process is happening where we're shunting blood away from the skin. And so you have to think there has to be there's a mechanism there that has to function, right? We have to have sympathetic uh, stimulation in order to constrict these muscles in the vessel, these little alpha receptors. So we have to have epinephrine secretion. And so that means our spinal cord has to be intact. And also that means the shock can't be caused by some kind of inflammatory process like anaphylaxis or infections like sepsis. And so in patients that are septic or in anaphylaxis or that have a spinal cord injury, we call these three types of things distributive shocks. And in distributive shocks, they're actually the problem in, let's use the example of sepsis. One of the primary problems in sepsis is that all of these precapillary sphincters are open. And so we're shunting blood to the surface of the skin, causing a drop in blood pressure. And so what do you think your patient's going to look like if they are in septic shock? Are they going to be pale and diaphoretic like this patient, or are they going to be flushed and dry and hot They're going to be that. They're going to be flushed and dry and hot. They may have pink skin. That does not mean they're not sick. And so as we move into paramedic level of training, we need to be a little bit more nuanced in the way that we assess patients because it's important to understand that you can have a patient that has very pink and warm skin that is dry, and they can be very, very, very sick. So as you we'll go through this more and more as we get into different types of in the nervous system chapter and in the immune chapter, but it's just important concept to start wrapping your head around. Last couple slides here, we have different functions of the skin. So vitamin D. Vitamin D is a really important, what we call covitamin, and a lot of different processes that occur within the body, uh, predominantly in our ability to absorb and maintain calcium balance in the body. And so vitamin D is very important for the absorption of calcium. It's also very important for our calcium regulation. So vitamin D is critical. So how do we get vitamin D? Well, there's two ways. We have dietary intake, which is a small amount, and then we also need some sunlight in order to get this this chemical process that occurs within the skin by the interaction of photons with certain cells within the skin that produce something called uh, cholecalciferol, which is vitamin D3. And so this is the same vitamin D3 that we can get through dietary intake, but it's much harder to get vitamin D through dietary absorption than it is through skin exposure to UV light. So this vitamin D3 goes to the liver where it's metabolized again in those hepatocytes, and then it's metabolized into something called 25 hydroxy vitamin D3, which then can go into the kidneys and becomes 125 dihydroxy vitamin D3, and this now can be utilized to help maintain both our phosphate balance in our bloodstream and prevent the excretion of critical phosphate, which is very important for bone function and cellular processes like ATP, right? Making ATP in our cells, but also maintaining bone density. And vitamin D also stimulates the absorption of calcium from our gut. And so when we're eating something, if we have low levels of vitamin D3, that's will not that means we're going to absorb less calcium from our dietary intakes. And so vitamin D3 is very important for bone density as well as cellular functions, because of our phosphate balance. And so this process happens, so one of the feedback loops that can happen uh, due to sun exposure. So important role of skin is vitamin D balance. Okay, next thing we have, as we talked already about skin cancer, basal cell carcinoma, melanoma, and squamous cell carcinoma. I could not remember the last word earlier, so I apologize. But yes, squamous cell carcinoma, basal cell carcinoma, and melanoma. So squamous cell is going to be cellular cancer, or I'm sorry, skin cancer of the squamous cells. So these are the keratinocytes. Basal cell carcinoma affects that basal layer or the stratum basal, and then the melanomas affect the melanocytes. And so there's a lot of different ways that we can associate these skin cancers or with different types of shapes and moles and colors and all sorts of things. But melanocytes think pigmentation. So usually melanomas are flat pigmented areas that can be either, like I said, hypopigmented or hyperpigmented. And they can be found anywhere, even in places that don't get sun, because it's not generally thought to be a UV sun exposure type of cancer. It is a skin cancer, and there may be some sunlight may play a role in some melanomas, but people get melanomas, like famously Bob Marley had melanoma in his toenail. It's what killed him. Lots of people can develop melanomas like below their pant line, things like that. And melanoma is the most aggressive. Squamous cell carcinoma, again, affects as you look for abnormal moles. Uh, and basal cell carcinoma, again, we're looking for abnormal skin growths and things like that. So when we're assessing moles, it's not something we commonly do. People call 911 to have their mole looked at. But it is something, as a medical provider, if you're assessing your patient and you can, say, hey, that spot looks abnormal. And then you can maybe, you know, advocate for them, hey, they have a weird looking mole. You might want to check out on their neck or something like that. But asymmetry is something that we look for that's abnormal. Borders or the edges irregular in shape. Color, think of hyper or hypopigmentation or moles that have different types of pigmentation within them. Diameter, usually if it's larger than 6 millimeters, that's something that could be concerning. And then evolving, if it's changing in shape. Um, those are bad. So skin cancers can be very horrible, and yeah, we'll learn more about them as we go on later. All right. Eczema. So eczema is an inflammatory condition that causes like dry, scaly patches of skin. It's an autoimmune type of disease, so it's treated with immunosuppressants and topical treatments. It is an antibody reactions, but it may be, like I said, immune triggering from environmental exposures. And dietary changes can also help. Maybe a dietary inflammation. But it's our immune system causing inflammation in the skin. And so that's eczema. Acne is another condition that we might see with skin tissue itself. So acne is where we get inflammation within the sebaceous glands, and we can get a significant inflammation. We get a little bacterial proliferate within that sebaceous area, and that gets a plugged follicle. And that causes the sebaceous gland is producing the sebum, but the follicle is plugged, and then the skin gets really inflamed. Um, it could be caused by the normal flora, which is Staphylococcus epidermis, just entering that hair follicle. Some other skin conditions are parasitic infections like scabies, which is an example of what's called helminth. Um, And dermatitis is another, which is inflammation of the dermis. And viral infections like herpes simplex, herpes zoster, and HPV are very common. Herpes simplex causes like cold sores, um, usually on the mouth, also on the genitals, and they reside in the nervous system tissue that can be found close to the skin. Herpes zoster is found more on the causes shingles, and that can be found in the oh geez, spinal nerve, and those spinal nerves and dermatomes that rise to the skin can create these streaking-like patterns that create this skin rash. Can be horribly painful. Can mimic patients feel like they present with symptoms of a heart attack, and they get these horrible viruses or horrible rashes. It can also cause things like chickenpox and things like that. So HPV is another form of viral skin infection which causes warts. It's also the leading cause of cervical cancer. So it can affect tissues within the body, the cervix. It can affect all sorts of areas of the body, but it does cause skin warts. All right, psoriasis is another autoimmune skin disease. It's very hard to treat. Usually, patients have to take some sort of immunosuppressant with psoriasis. Impetigo. This is a skin infection that's highly contagious, caused by streptococcus bacteria, particularly the strep A. And when you can develop these crusty rashes, oftentimes on the face, around the oral cavity, like on the edge on your lips, and it's treated with usually just a topical antibiotic, but it can be also lead to things like as you know ominous as bacterial meningitis, things like that. So impetigo is commonly seen in kids, but adults get it as well. Hives is inflammatory response, uh, creating uh, hives. We'll talk more about that later in the immune chapter. Cysts, again, we talked about those already. So those are different types of things that we can see. Injuries to the skin, we have all sorts of types of injuries. You're going to learn about this in more in your classes that you're going to take after this, so I'm not going to spend a ton of time on this, but we have abrasions, lacerations, and avulsions. These are different types of ruptures in the skin. And so abrasions, we're talking surface layer down to the dermis. Lacerations can go through the epidermis, and dermis is what deep all the way down into the hypodermis and even deeper. And abrasions are caused by like friction, where lacerations are usually caused by some sort of sharp object. And then avulsions is where we create like a flap of tissue and we're taking a chunk out. Then other types of skin injuries like contusions and hematomas, these are just bruises, a collection of blood underneath the skin without rupturing the skin. Burns, we have thermal, electrical, steam, liquid, chemical. Again, we're going to talk more about burns, or you're going to learn more about burns as you go on, but we classify burns by thickness, and burns are classified as partial thickness, superficial, partial thickness, and full thickness. And full thickness burns, we used to say first, second, third degree, and then full thickness burns also encompass what is called fourth degree burns, which is not commonly talked about or classified in the field because it's difficult sometimes to see. But fourth degree burns are where the burn goes, the eschar goes all the way down to the bone. So you have the underlying skeletal tissue here, and the burn has gone all the way down. So if you have full thickness burns, we're going all the way through the hypodermis. Partial thickness burns, we're going into the epidermis, we're causing blisters and potentially into the dermal layers, but nothing below that at all. And then superficial is just out on the outer surface of the epidermis. Other things to talk about a little bit are our healing process. And so when we have an injury or laceration to the skin, this stimulates release of growth factors from the cells themselves. And some things called insulin-like growth factor. We'll learn in our endocrine chapter that insulin is a big stimulant of cellular growth. And cells can release something like called insulin-like growth factor, which is IGLF, insulin-like growth factor. Or sorry, ILGF, which would be whatever. You guys get the point. So insulin-like growth factor gets released from a cell when it's damaged. It releases this compound, and then it says to the cell, this stimulates fibroblasts within the connective tissue to start making more connective tissue. And it also stimulates regeneration of cells. It can help stimulate cellular growth, and it stimulates, just think about it, it's an upregulator of anything related to cell growth. And part of that is going to be these fibroblasts to lay down new tissue. And let's say I have a big, deep laceration. So here's my laceration. And part of this release of insulin-like growth factor is to help re-epithelialize this skin. And our skin will try to draw these edges together as much as it can as part of the healing process. But if it can't, the rest of it is going to get filled by these fibroblasts, and we'll get this cartilage or this fibrous connective tissue. And we probably all heard of that. That's called a scar. And then something called a cleoid is basically scar tissue that's like extending above the wound like this. And this is stimulated by an increase in fibroblastic activity and a wound where we aren't able to fully re-epithelialize that tissue. So one thing to important to note is that scars are weaker than fully reepithelialized tissue. And so like surgical incisions are common sites for areas of like hernias and things like that because the that scar tissue that forms is weaker. So we try to do as much as we can to reduce scar formation by bringing those wounds closer together, stimulating healthy skin growth, things like that. Um, like we talked about this term cleoid, we also call it a hypertrophic scar because it's caused by hypertrophic fibroblastic activity, and that's extending beyond the margins of the wound. Okay, let's talk about skin ulcers. Very important because these are a big cause of mortality and sepsis in particularly the elderly, but anybody can develop an ulcer if we create the right conditions. And so an ulcer is specifically a pressure sore, is caused by continuous pressure on an area of skin that's going to cause a tissue breakdown. And what happens is if I let's say fell and was stuck on the ground in a position, or I would, just had surgery and I'd been laying in bed for multiple days without moving off my butt, and I'm sitting on one spot. That pressure on that tissue causes a lack of blood flow to that area. Whether you're sitting in a chair right now, there's less blood flow to your hips and your area of your skin. There's less blood if I were to fall down on my hip, there's less blood flow to that hip. And so what happens is if I sit on that spot for, not that long in some patients, with studies done with patients on backboards, about 20 minutes was long enough to start the development of an ulcer. So um, in the stages, just like burns, we have kind of superficial, uh, partial thickness, and full thickness. And they form in stages. Stage one is just like a red area, devascularization, lack of blood flow, and we're starting to have some serious tissue ischemia and inflammation. Then in stage two, now we're starting to have tissue necrosis that's down into the dermis. And then in stage three, tissue necrosis all the way down towards through the dermis. And then stage four, it's full thickness all the way down to the bone. And the thing is, just relieving the pressure is not enough to treat these wounds. So because we've damaged the blood supply by the tissue by creating ischemic necrotic tissue, just simply like moving the patient, once the ulcers have started to form, they can progress. And so it's really important to assess your patients for these red spots of redness. So, like if you go to a patient that's had a fall and they've been down for multiple days, uh, that's not a patient you probably want to pick back up and just put in bed without doing much of an assessment and say, okay, bye. Uh, that's going to be a patient that's going to likely have some significant comorbidities from that event. Um, and we want to make sure that we're assessing areas of pressure like the hips, glutes, things like that for these red spots. And then if you see that, that can be an indication of a pressure sore, pressure ulcer. The problem with these is they develop horrible infections, and it's because they're necrotic tissue. We'll talk a little bit about certain types of bacteria a little later, but uh, there's a we have aerobic bacteria and anaerobic bacteria. Anaerobic bacteria love dead skin. So they love burned skin. They love areas of necrotic tissue like foot diabetic ulcers and pressure sores. And they like to get into those places because there's not a lot of blood flow to there. So there's a lack of oxygen. So they thrive in those environments and they can get set up shop and get colonized in these little ulcers. And so this can cause horrible infections like Clostridium perfringens, which is gangrene. It can lead to severe sepsis. It can also lead to amputation of limbs and things like that. And it doesn't take long with pressure in a certain area to cause that, less than an hour. So keep it in mind as we're doing assessments. It's a critical part of your physical assessment in high risk populations to look for these things. It's also why we probably don't want to put someone on a backboard and leave them in a hallway for 30 minutes because they're likely just going to not have anything wrong with their spine, but they're going to develop a nasty pressure sore from sitting on that backboard. So keep all those things in mind. Thanks for your attention, and we'll talk again soon.